Transplant is not a foolproof surgery by itself. When you say that there is a 92 to 95% chance of success, that means that this is a surgery where there is a 5% risk of mortality also. But a 5% mortality is for a patient who otherwise would have a 100% mortality. You understand? This is a disease which has no treatment. End-stage liver disease has no medical treatment. You can only stabilize the patient and optimize them till they get a transplant. So all these patients, as I said before, would otherwise die. But now because of transplant, 90 to 95% of them are living and they do well. And because the liver is a regenerative organ, they continue to live for long periods of time. Okay. Now, complications could be related to the surgery per se. Most likely these are infections because you immunosuppress these patients after the transplant because it's an organ from another person. So when you decrease the immunity of a patient, infections become the number one cause of complications in these patients. Technical complications in terms of the blood vessels that you join, them getting blocked or them having some bleeding is to a minor percentage, maybe 2 or 3% of the time. But overall, these complications are probably amongst the major ones that you look at in post-transplant patients. Regarding ICU complications?
In the ICU, usually as Dr. Gurprasad has said, that transplantation is a very complex procedure. It's not an easy thing. That is why it is not being done in most of the centers. We need a kind of license for having a transplant done in any center. So why it is complex? Because in the post-transplant period, we often see a lot of systemic problems, like their blood pressures might fluctuate for a couple of days. The bleeding might happen for a couple of days. Those things need to be monitored, treated. They might require artificial breathing support, ventilator support for a few more days. So those things need to be managed based in an intensive care unit. The idea of having robust intensive care unit support is to give each and every organ the adequate support which it requires and which might become stabilized after a few days of time as soon as the liver starts working on its own. So that is the sole idea of having a robust ICU support.
Ailments like having heart ailment or having kidney ailment. So he approaches for the dedicated liver ICU. So does the ICU cater to his other needs?
Suppose that now same question what she asked, what is the ICU? Basically, patient report when he comes to the hospital, it's possible that he comes only for the heart. It's possible that he comes with the kidney, and then subsequently after 2 days you realize that in addition to the heart and kidney he had a liver problem. So now to answer your question, primarily when patient comes to ICU, primarily we assess the patient, we make a provisional diagnosis. At that point of time, it's possible that he had hypertension, kidney, heart, brain. So that point of time, what we see, what is the topmost priority for which the patient comes to the hospital. And suppose we feel that point of time that yes, he has a cardiac issue, so he goes to the cardiac ICU. That point of time, suppose we know that primarily it looks like there is a liver issue, he goes to the liver. So the idea of liver ICU is that the liver doctor might come and say, just give an example that this gentleman requires a lot of water. But again, the cardiologist comes and he says, his heart is very weak because he has angioplasty, he requires less water. So our job is to just fine tune everything and do what is the best appropriate care at that point of time, which is the topmost priority that moment. Coming to your answer, yes, it's possible that the patient comes to the liver and he has a cardiac issue and all that. So we are in the situation to handle that. But that point of time, as the problem is starting with the liver, he or she goes to the liver ICU.
I will just expand this a little more. Most hospitals will have ICU, well-equipped ICU and all. What we are talking about here is a dedicated ICU for liver diseases, not only for transplant. Most centers which are doing transplant will have a transplant ICU, limited number of beds. Here we are talking about, and it's always a multidisciplinary approach, like what Dr. Akshay just mentioned. So, whatever ailments patient is having, it's a multidisciplinary. If patient has a cardiac issue, the cardiology is also part of the team. But the point here is that the liver ICU by a dedicated liver hepatologist and intensive care specialist, and the rest of the staff is also trained to look after the liver patient. So it's dedicated staff which is only looking after the liver patient. Any additional ailment will always be supplemented by the respective teams.
INR is a value that tells us how bad the liver dysfunction is. The liver INR बदलेल prothrombin असा घटक बनवतो. It makes prothrombin, and what we measure is prothrombin time when we look at INR. At the same time, the synthetic function of the liver different also. So it is albumin level, the serum albumin level that helps us to identify how sicker the patient is. At the same time, other parameters like bilirubin, other parameters like interleukin, EJ, CPT score different also, ascites in that from. There are various parameters. This is not a single parameter, but a composite score of multiple parameters that help us to decide and stratify this patient is having a mild, moderate, or severe. Prothrombin time असं एकच व्हॅल्यू बघत नाही, आपण मल्टिपल हे जे घटक असतो एकत्र स्कोरमध्ये कॅल्क्युलेट करतो, आणि जेव्हा हा स्कोर आता मेड स्कोर आहे ज्याच्या आपण डिसाईड करतो किती सिक पेशंट आहे. कुठलाही मेड स्कोर 15च्या वर गेला तर आपण म्हणतो की याला ट्रान्सप्लांटची गरज पडू शकते. आता हा मेड स्कोर जर 30-35 असला तर हा पेशंट जास्त क्रिटिकल असतो, आणि हा जो मेड स्कोर आपण कॅल्क्युलेट करतो एका घटकाने होत नाही. बरेच जे ब्लडचे पॅरामीटर्स असतात, बिलिरुबिन व्हॅल्यू, ॲल्ब्युमिन व्हॅल्यू, आयएनआर व्हॅल्यू, क्रिएटिनिन व्हॅल्यू, हे बरेच पॅरामीटर्स एकत्र करून आपण हा स्कोर कॅल्क्युलेट करतो. So it is not a single test, but various multiple tests that help us to define and determine कि या patient में कितनी खराब liver disease है.
Failure or
transplant surgery would be the best person here.
Yeah.
what is the percent of failure in making the?
So fortunately, the liver that way is a very friendly organ. It grows and it comes back to the original size, and it also doesn't require that kind of matching required for a kidney transplant. So just a blood group that is compatible to the blood group of the patient can be a donor, provided they are related in the family, or if you're getting a cadaveric organ, then we need the same blood group. So why we need the same blood group in cadavers? Because cadaver organs itself is a scarce resource. So only those patients' organs which match with your in terms of blood group are given to you. But when it's a family donor, any blood group that is suitable to the blood group of the patient, you can give the organ.
And does the donor also require ICU?
The donor, for precautionary reasons, spends 1.5 days in ICU, as in half a day of the surgery, after the surgery, and another day. But overall, it's not that they are critically ill that's why they require the ICU. It's just for observation and monitoring, and then they shift back to the ward.
And so I think यांच्या जे म्हणाले डॉक्टर गुरुप्रसाद म्हणाले अबाउट ट्रान्सप्लांट, पण त्या ट्रान्सप्लांटला पोहोचण्यासाठी लिव्हरचा पेशंट जो प्रॉब्लेम्समधून जातो आणि जे प्रॉब्लेम्स असतात म्हणजे लिव्हरमुळे मेंदूवर तणाव पडतो, लिव्हरमुळे फेफड्यांवर तणाव पडतो, किडनीवर तणाव पडतो, याला इंटेन्सिव्ह केअरची गरज पडते. हे आपण घरी ऑन ओपीडी बेसिस सॉल्व्ह नाही करू शकतो. सो फॉर दॅट आयडिया ऑफ giving them the best care before the transplant and obviously after the transplant, and that is where the liver ICU comes into the picture.
So just to add to that point, what I would also like to say, you all to register is that very often we have relatives, friends, or people we know who are on dialysis. Kidney patients that dialysis चालू आहे, आठवड्यामध्ये 2-3 dialysis is on, or maybe less or more frequent. There is no machine for liver. You understand? So it becomes that much more critical for a patient to be sustained till their transplant. Dialysis, why patients are on dialysis? Because they get the next organ, or when they become ill enough to get a transplant, they will be on their dialysis. There is no such machine in the liver. So you have to handle each patient as an individual. If he has kidney affection, kidney का treat करा. If he has liver, if he has cardiac issues, if he has lung issues, that all needs to be optimized and brought to a stage where finally we can transplant them. असं नाही की कोणी पण आलं we just do a transplant. So they need to be optimized, and that is where this whole liver ICU comes into perspective. Because they are very fragile patients. You know, everyone, you'll never find a liver patient who has just had one hospitalization and transplanted. they will have multiple hospitalizations, they will be having multiple problems because of their liver disease, and all those need to be managed crucially and critically till the time they can be reached to a stage of transplant.
One more thing I want to tell a bit of story to tell. Not necessarily all liver diseases will land up in liver transplantation. So I would request Sori to give some stories or some patient details which we have treated, which actually went home without requiring liver transplant and now they are living normal life.
म्हणजे अपोलो असो कोर्टेज असो हॉस्पिटल आहे ह्या मोठे कॉस्टली आहेत त्याच्यामुळे गरीब पेशंटला कोर्टेजमध्ये किंवा इतर सुविधा कसं परवडण्यासारखं काय आहे.
सो बऱ्याच वेळा हे आजार द नेचर ऑफ सच आजार त्याच्यामध्ये कॉम्प्लेक्सिटी खूप जास्त असते. बऱ्याच वेळा पेशंट वेळेवर आपल्याकडे पोहोचतो किंवा नाही, त्यांचं पहिली ट्रीटमेंट झाली आहे किंवा नाही, हे खूप मोठे मोठे फॅक्टर्स असतात. ह्याच्यामध्ये दोन पद्धतीचे असतात, जसे सगळी लोक म्हणतात ते होतं. अल्कोहोलिक डिसीजमध्ये बऱ्याच वेळा आमच्यासारखी जी हॉस्पिटल आहे त्याच्यामध्ये फंडिंग रेज करणं खूप डिफिकल्ट असतं, कारण की कुठल्याही चॅरिटेबल संस्था किंवा कोणीही ह्या फंडिंग करण्यासाठी तयार होत नाही, कारण की हा आजार स्वतःच्या सेल्फ इन्फेक्शन किंवा सेल्फ याच्यामुळे होतो. बट अदर जे आपण म्हणतो त्याच्यामध्ये बऱ्याच प्रमाणात चॅरिटेबल इन्स्टिट्यूट किंवा समाजाचे काही जे डोनेटर्स आहेत ते पुढे येऊन ह्या आजारांमध्ये मदत करण्यासाठी तयार होतात. बरेच असे लहान मुलांचे लिव्हर रिलेटेड डिसीज आहेत किंवा मोठ्यांचे आहेत त्याच्यामध्ये आम्ही स्वतःहून बाहेर जाऊन चॅरिटेबल फंडिंग रेज करून ते ट्रीटमेंट केलेली आहे. तुम्ही जसं म्हणता ह्याच्यामध्ये ओव्हरऑल कॉस्टिंग खूप जास्त प्रमाणामध्ये असते, कारण की याच्यामध्ये लागणारी जी औषधच असतात त्याच्यामध्ये इन्फेक्शन म्हणा किंवा अल्बिनिक असं ड्रग आहे जे जास्त प्रमाणात लागतं, त्याच्यामुळे कॉस्ट जास्त असते. त्यामध्ये जितकी मदत करण्या येण्यासारखं आहे त्याच्यामध्ये आपण करतो आणि मी जे म्हटलं चॅरिटेबल सोर्सेस आहेत आणि त्याच्यामध्ये आपण त्यांना मदत करण्याचा प्रयत्न करतो.
But till now, if you look at the history of the liver disease in India, because alcohol was very common. But now, over the last decades, because of westernization of our culture, because of poor eating habits, lack of exercise, sedentary lifestyle, stress that we all have, we have a new epidemic that is coming in, which is called as metabolic dysfunction associated steatotic liver disease. Now, what was called as NASH or non-alcoholic liver disease has now been renamed, and it is more of a gamut of multiple issues that a liver patient will have. Now, predominantly, any patient who is having a liver disease because of alcohol will have obviously symptoms for alcohol withdrawal also, which these patients with fatty liver disease would not have. Fatty liver disease patients are diagnosed pretty late because it takes time for that liver to become eventually cirrhotic. It doesn't happen over a period of time. It takes time, at least 10 to 15 years. And in this particular time frame, they may not have any symptoms. So that is where the idea of doing health checks comes in, where we can diagnose these patients early, where we see their liver functions are a bit deranged, or if they have a fat in the liver, then we evaluate them further using a fibroscan. These patients will not have any symptoms for that matter. It is only when the patient's liver becomes cirrhotic and there are complications because of cirrhosis of the liver, that is the point of time we pick them up, and that is eventually late. So, to answer your question simply, there is no such symptom that a fatty liver patient would have, apart from mild discomfort. If at all the patient has 20% or you complain about that. So, doing a regular health check to pick it up early, I think amongst all of us, 4 of 10 will have a fatty liver disease, and it's a fact. That's what the data tells us, and it's a fact. When we look at health checks, that's what we come to know, and hence it is very important to do a regular health check. Now, when these patients eventually have symptoms is when the liver is already cirrhotic. Means that liver kharab zala hai, 80% cover, and then they have complications like पेट में पानी भरना, ascites that we have, or affection of the kidney, they become jaundice, that is obvious, and that is the point of time when they come for help. The idea is to catch them more early and not that late.
मराठीमध्ये सांगू, मराठी इज नॉट व्हेरी क्लिअर, सो
कन्नडमध्ये सांगितलं तुळूमध्ये सांगितलं तरी चालेल.
मग फक्त आपण दोघंच बोलणार. सो डायबिटीज ना एक सिस्टमिक इलनेस है, हर ऑर्गन बॉडी में अफेक्ट होता है. एवरी ऑर्गन यू कैन, इट मे नॉट प्रेजेंट इटसेल्फ, इट मे प्रेजेंट इटसेल्फ, बट डायबिटीज इज अ सिस्टमिक इलनेस. असं नाही की फक्त डायबिटीजमुळे फक्त लिव्हर खराब होतं, अंडरस्टँड, बट देर आर सम organs which will get more affected than the other organs, and diabetes is presently, I think, it's a lifelong illness. That's also it's just ongoing. It's just a question of how well you control it during the entire stage of the illness. So, major affection that I think so far we've seen is with the heart, but liver also does get affected, and that is what is becoming more and more prominent or eminent. Now, you have to look at it just as Dr. Amani Sangile, it's a cohort of symptoms. So when you look at it, diabetes affects the metabolism, and the metabolism will also affect the liver. What has happened nowadays is we have poor food habits, we have sedentary lifestyles, lack of exercise, and easy high calorie food on the click of a button on the phone has become available to just about everybody. So this habit or the group of habits is what is affecting everybody, and each one's some organ will get affected in that process. Some people's heart are getting affected, some people's liver is getting affected. So, and because of the awareness, the liver is also getting picked up earlier and earlier, so we are seeing that fatty liver becoming that common. And as Dr. Amay said, amongst this whole group of fatty liver, some percentage will go into inflammation, some percentage will go into fibrosis, some will go into cirrhosis, and some major part of those cirrhotic patients will end up in our liver ICUs or in hospitals with some sort of problem following that cirrhosis.